MCA stroke features and the assessment of patient who diagnosed with MCA stroke. Hello everyone, welcome in my channel Romana Physio. Let's study together and make physio easy. So, friends, first of all we are starting with the MCA stroke features and then we'll discuss about the assessment of MCA stroke. So the features are first of all MCA, which is the middle cerebral artery that supplies which parts? So it supplies the lateral aspect of cerebral hemispheres, in that the frontal, parietal and the temporal lobes. Then second is the subcortical structures that including internal capsule. Okay, that is what about the posterior portion. Then corona radiata, globus pallidus, that is outer part, and most of the caudate nucleus and putamen. These are the structures basically which is supplied by the middle cerebral artery. Then here we discuss about the features. That means what about the sign and symptoms we have to write in the answer. So first we discuss about the structure and involvement, and due to that structure involvement what type of sign and symptoms is present. So first is primary motor cortex and internal capsule is affected. So which type of symptoms? Like contralateral hemiparesis. Hemiparesis means what? The weakness only, and the contralateral means on the opposite side. So that involved mainly upper extremity and face. The lower extremity is less involved, or in some cases it is intact, that is normal. So that is what about the first features. Second is primary sensory cortex and internal capsule involvement. So the features are contralateral, that is opposite side, hemisensory loss, that is sensation loss, and it involves the upper extremity and face. Same, lower extremity is intact. The third is if the Broca's area is damaged, so the motor speech impairment, that is Broca's aphasia, is present. That also known as non-fluent aphasia. In that what happened? Limited vocabulary and slow speech and hesitant speech. Then fourth is if the Wernicke's area is affected, that is posterior portion of temporal gyrus in dominant hemisphere. So the problem is the receptive speech, that is what about the Wernicke's aphasia is present, and that also known as the fluent aphasia. Then both third frontal convolution and posterior portion of superior temporal gyrus, if that is affected, so global type of aphasia is present, that is non-fluent speech with the poor comprehension. Patient have difficulty in comprehending with the examiner. Then parietal sensory association cortex, if it damaged, so the symptoms are the perceptual deficits like unilateral neglect, the depth perception, spatial relation disorders and agnosia. So this type of symptoms is present. Then premotor cortex or the parietal cortex, if it damaged, so limb kinetic apraxia is present. So basically apraxia means what? The impairment of voluntary skill learn movement. Patient जो voluntarily नवी movement learn करे, that is impaired. So in that we have different types: idiomotor, ideational and buccofacial apraxia. But here the limb kinetic type of apraxia is present. Then optic radiation, if it is damaged, so the problem is contralateral, that is in opposite side, homonymous hemianopia is occur. Then frontal eye field, if it is damaged, so the problem in loss of conjugated gaze to opposite side. Conjugated gaze means what? Whenever you turn your eyes, so the head is also turned on that eyes direction, so that is affected. And if parietal lobe is damaged, so ataxia of contralateral limbs is present, that is what about the sensory ataxia. So these are the features of the MCA stroke, that is middle cerebral artery involvement. Now we discuss about the assessment part. So assessment of patient who diagnosed with the MCA stroke. So first of all we start with the demographic data, that is what about the name of the patient, but in the question if it is given you have to write or otherwise not. So first is name of the patient, second is age, if it is given you have to write, then sex, either male or female, occupation of the patient, then dominant side and date of administration. Then about the chief complaint of the patient. Now just see the features. So in that patient have more involvement of the upper limb. So chief complaint is what? Patient having difficulty in moving upper limb and lower limb, and difficulty in speech and facial weakness, and the lower limb difficulty is less than the upper limb. So this is what about the chief complaint of the patient. Now we start with the historical part. So history is what? First is present history, past history, medical history. So in this type of stroke patient, generally antispastic and anti-blood coagulant medication is useful. So આપણે લખી શકીએ medicine like antispastic, that is baclofen etc, and the anti-blood coagulant medicine. Then about the personal history, like કોઈ addiction છે or sleep pattern શું છે patient ની, and appetite. Okay, so that is included in the personal history. And social history. Then on the observation, first of all we have to observe the BMI of the patient for by the age and the height. Weight and the height. In other words, we have to calculate the BMI. So in that body build, either patient is endomorphic, mesomorphic or what. So એ આપણે include કરવાનું છે. Then second is attitude of limb. So basically in the MCA stroke, the upper limb is more involved. So you have to write the upper limb involvement is more rather than the lower limb. Then postural assessment, basically in this setting, in lying and in the standing position, you have to check out. So in sitting, affected side shoulder weakness is present because of the upper limb involvement, and affected side face, that is drooping. So this is what the postural assessment. Then any type of deformity if present, so write that. Then external appliances due to deformity or deformity prevention, the therapist applies some external appliances like the upper limb orthosis is given to the patient or walking aids etc. Then on the palpation, you have to check the tenderness which is not present, skin temperature, that is warmth, swallowing or edema may it is present at the distally in the MCA patient. Then on the examination, first of all you have to examination in SOAP wise we can't include the neural examination, but in the neuro case, the MCA, it is the neuro case, so we have to examine the higher mental functions, that includes the orientation of the patient. So in the MCA patient it might be altered. Then memory of the patient, it is affected long term and as well as short term, both memory are affected. Then behavior, it might be affected. Speech, that is non-fluent aphasia, the fluent aphasia and the global aphasia which is present into MCA patient because of the structural involvement of the Broca's and Wernicke's area. Then cranial nerve examination, which is also including neuro examination. So cranial examination, basically the facial nerve examination and vestibulocochlear nerve examination we have to check because it is more affected in MCA patient. So if we check the facial nerve examination, they tested by facial muscle movement. Okay, we have to check the different muscle movement which is supplied on the face. So that is about cranial nerve examination. Then motor examination, in that we have to examine the girth measurement, that is either we have to check the atrophy or dystrophy or any type of hypertrophy is present or not. Then second is tone examination, that is either hypertonia or hypotonia, which type of tone is present in the patient. So basically in MCA stroke, patient is suffer from the hypertonia in the upper limb, and that is basically spasticity. Then VCG grade we have to check if patient is available. Then in reflex, that is you have to give a grade. Okay, give grade, like if grade 0, the no response, grade 1, that is low response, grade 2 plus, that is normal, 3 plus, that is brisk than normal, and 4 plus means the hyperactive reflexes. So we have to check about the deep tendon reflex. So in the biceps, triceps and supinator jerk are affected because of the upper limb involvement is more, and the knee jerk and ankle jerk might be normal. Then myotomes testing, so upper limb myotomes is affected. Dermatomes, that is we check by the root values, okay, and area wise. So in that sensation is affected on the upper limb and the face, and lower limb sensations are basically normal. Then about the range of motion measurement, so in the joint we have to check about the all the joint, so basically affected in upper limb and lower limb and the spine. Then check for the LLD, that is limb length discrepancy. So and next is check the balance, that is static as well as dynamic balance you have to check. So in MCA stroke patient, basically dynamic balance is affected and it is more in the upper limb. Then check for the coordination, like you have to check about the different tests like non-equilibrium test and equilibrium test. So such example like finger to finger test, finger to nose test, heel to shin, the rhombic sign you have to check, and the tandem walking. So these are the such example of the coordination test. Then bladder and bowel control, so you have to ask to the patient about the normal bladder and bowel activity. So it might be normal in the MCA patient. Then functional examination that include the such activities like eating, bathing, toileting activity, combing activity, dressing, drinking, so that all are affected. Why? Because in the MCA stroke patient, the upper limb weakness is more. So this activity basically involve more upper limb, so that all are affected. And then investigation, so you have to check or rule out the investigation like CT scan, MRI of the patient, blood test, angiography, that is cerebral angiography, and PET scan. So these are investigation which shows the final diagnosis. Now the provisional diagnosis is what the MCA stroke and problem with the ADL, that is our diagnosis in clinically. So according to investigation, the diagnosis is what MCA stroke and problem with the activity of daily living. Now the problem list of the patient. So speech problem, ADL problem, that is activity in daily living, weakness which is basically more in the face and the upper limb, altered coordination, speech problem, swallowing difficulties, visual problems, then loss of range of motion and disuse atrophy. So these are what about the problem list of the patients who suffer from the MCA stroke. So this is all about the assessment, and lastly you have to just include about the PT management, that are short-term goals and the long-term goals and follow-up. So thanks for watching my video. Thanks for watching my video, and if you like my video, please give thumbs up and share with your friends, share knowledge, and subscribe my channel for more videos.